Next, we are honored to have an outpatient panel discussion, which includes the following people: Ben Woodard, Tom Lincoln, Rachel Katz, and Annie Potter.
As we wait for folks to unmute and to activate their videos, I am honored to welcome everyone here to our outpatient panel discussion. Thank you, everybody. So I'd like to do more formal introductions with everyone. First, we just heard from Rachel Katz. She's the Director of Integrated Substance Use Services and lead nurse in the Community Health Center of Franklin County. Ben Woodard is Physician Assistant at Baystate Franklin Emergency Department. In his prior life, was primary care and addiction medicine at Valley Medical Center in Greenfield. Nurse practitioner. Annie Potter, nurse practitioner and clinical nurse educator for the OBOT TTA program at Boston Medical Center. And she also serves as the medical director of the Massachusetts Opioid Treatment ECHO panel, and is also board certified in addiction medicine and specialty certifications in HIV and hepatitis C. And Tom Lincoln, who is a primary care internal medicine physician at the Baystate Brightwood Health Center, has been providing buprenorphine since 2003, and also serves as medical director of the Hampden County Correctional Center. Thank you, everyone, for being here today. It's really an honor to see everyone. What I would like to do is kind of present this in more of a case-based format. And, you know, what we have is a lot of different providers in the outpatient setting. I think where we are is folks, a lot of folks with interest, some with some basic experience, but really trying to make this more accessible and bring resources to the outpatient, which you are all experts in. So the first case is a 35-year-old, a history of hypertension, who presents for an outpatient visit. You've known the patient for 5 years, and you've addressed the hypertension at the annual visits. But at this visit, you learn that the patient's been using heroin for the past 2 years. In fact, he had a recent overdose for which he was seen in the emergency department, which made him really start to consider wanting to stop. He's interested in medication treatment. He's otherwise healthy. He has family supports. You know, your usual practice has been to refer these patients out. There is a for-profit addiction treatment center which you kind of refer folks out to, and you've kind of had mixed results with that. So, Ben, I want to start with you. Why can't I just continue to refer these patients out? We as medical providers have a lot on us, and why add something else to our practice? What is the benefit of that?
It's an awesome question. You can hear me okay? Great. So I think this attitude, I think I'm getting a lot of background noise from somebody's computer there. I think this speaks a lot to the sort of social segregation of addiction, which goes along with literal racial segregation in our country. I was grateful that Rachel brought that up in her talk. And frankly, our complacency with this, it is the insistence on referring this out as a form of structural violence, as far as I see. We're generalists, most primary care providers, which means that we have this moral obligation to be at least moderately competent at managing whatever walks into our room. If you're residency trained, if you're trained as a family practitioner and you're boarded in that specialty, you're supposed to be able to get a sense of how to manage renal failure when that walks in. Yes, we can consult with and refer to nephrologists, but most of the time it comes back on us to manage the patient because of our rapport and our knowledge of their life and what makes them tick if we're doing our job right. And so, yes, we can send our patients to endocrinologists or cardiologists to get the 2 cents, but ultimately they come back to us. And there's no addictionologist in the community who, to use a phrase from one of my mentors, Coty, that we get to just speak to in the email. I think the other thing is that if you think you are not dealing with it, with addiction in your practice, you're fooling yourself. I would wager that for this case, for example, this 35-year-old guy, you didn't have their hypertension under control if you weren't addressing their addiction. You weren't adequately addressing, a lot of those preventative and secondary prevention measures that we do. Once you start seeing addiction in your practice, you start understanding and realizing why McGillicuddy never really prioritized her insulin or changed her diet. And I don't think that you can actually treat comorbid chronic disease without treating the number one comorbidity that affects them all. So that would be my response to this idea of why can't we just refer them out? It's our job. And we have, I've personally seen primary care thrive, and frankly, when the access issue opens up, do in some cases above than proprietary models. That we have some really excellent access that is granted by proprietary models, and I would argue the person who knows the patient best does best by them.
That's great. Thank you, Ben. I think it really does, highlight that those that are their primary providers really know this patient the best and really have that worldview. And I think since we have a lot of folks here, we likely have the folks that are interested in taking that first step and realizing that that first step can be hard. And I want to turn to you, Rachel, in thinking about taking that first step in your practice of treating your first or your second patient, how do you get started with that? How do you get started when you're first thinking about offering treatment?
Yeah, so that's a really excellent question, and really kind of the nuts and bolts of why some folks are here tonight. So I completely agree with Ben. I think that if you are not seeing addiction in your practice, then you are likely choosing not to see it, or are just it's under your radar. And I will sort of counter that with, once you start seeing it, you won't stop seeing it. Like, once it's there, then you are going to start seeing it everywhere. And there's this really definite shift that happens with your patients and with your patients and their family members. Once I started treating addiction, it was like the floodgates opened, and all of a sudden, parents and siblings and partners were coming in and talking to me about the drug use in their families. And so it's not just a patient-centered issue. I think as family providers and as primary care providers, we really treat families and we treat family systems, and that's what this is all about. In terms of getting started, your first couple of patients, again, they're there. Like, they're right in front of you. They're your patients. You know them. These aren't necessarily people who are just walking in off the street and wanting addiction treatment. These are the 35-year-old guys that you've been treating for the past 6 or 7 years. This is the 43-year-old woman who potentially has been drinking for most of her life and is now just telling you. You have relationships with these people, and so addressing their addiction, their substance use disorder as one of their many chronic diseases is just a natural part of this process. And I really encourage people when you're first starting out to also be really transparent with your patients and say, look, I'm brand new to this, but I really care about you. I want you to be safe. I want you to be healthy. I am learning as much as I can. And so let's do this together. Let's walk this journey together. Let's continue to capitalize on this relationship, and we'll see where it goes. So.
That's great. Thank you. I think one of the things that people look for, and start this, all of us are looking for, what are those resources? What are those tangible things that I can have or people that I can turn to as I'm thinking about establishing this in my practice? And Annie, I want to turn to you on this because, this is kind of what you've been doing for, I think, a long time is helping others with this. And so I wonder if you can tell us, from your end, how do you go about helping folks to really establish this in practice? I'll tell you, you're muted.
Yep. So, a great place to start, as Rachel discussed, was the Boston Medical Center Office-Based Addiction Technical Training Assistance website. So it's www.bmcobat.org. There you can find clinical tools, forms, the nurse care manager guideline, and also clinical algorithms. And just kind of spoiler alert, the clinical algorithms will now become an interactive application that you can download onto any iOS or Android device and available on the web. That should be coming early December. That will also be linked with the clinical opiate withdrawal scale, your audit for screening for alcohol use disorder, and a quick link to journal resources. So just look out for that. That should be launching December 1st. There you can find, treatment agreement plans, forms. You don't have to start from scratch. And we are not the only resource. There's the Provider Clinical Support System. They have resources. They have clinical tools. They're actually launching a program called PCSS Exchange, which is exactly for people starting off in addiction care. It doesn't matter if you are in a solo standing private practice or if you're working in a community health center or in a larger institution, kind of meeting people at all different practices that they have. Another great book that I always have in my PDF file of resources is SAMHSA has a series of treatment improvement protocols. And the one that kind of focuses on medications for opioid use disorder is tip 63. There it will go over any kind of questions you may have about regulations. They also have sample treatment agreement forms, questionnaires of screening such as the DSM-5, also for COW scales, like all those clinical resources and tools and assessments that you need are all available. They also are very up to date in practices. They just came out with one about addressing methamphetamine use, which I know is prevalent all across the country now, unfortunately. Also, meeting people with co-occurring substance use and mental health disorders. So that's a great place to go. The nice thing about the Tip 63 now is it's available in a PDF, and you can Control F and find the exact resource that you need. You don't have to go through all 300 pages. And lastly, the American Society for Addiction Medicine, they just updated their national practice guidelines. They also have sample documents that you can find. So these are all 4 great vetted resources, so you don't have to start from scratch. I know we all talk about the importance of the 42 Code of Federal Regulations Part 2 that can be integrated into your HIPAA agreement form. Those are all found in all 4 of those places, so you don't have to ever start thinking of a treatment protocol, guideline, agreement forms from scratch. They're all already available. And as Rachel plugged us, if you have something that is specific to your institution or for your community health center or your practice's needs, we do specialized training and we can reach out as needed.
That's amazing. It's such a great resource, and we will post those resources in the chat as soon as the panel is done. So I want to reiterate the fact that all of this is out there and it has been created, and I think for a lot of us and a lot of thinking about regulations and things like that, it's focused on wanting to treat patients, right? It's focused on we want you to expand treatment and to help you do that, not to penalize if there is something minor. And so definitely thinking about that. Turning back to those first few patients, really, I think part of the goal in starting out is to select some patients that are going to give you a good experience, because it can be really frustrating if you start with something very complicated and it's really hard and doesn't work out. So I wonder, as you're starting on this, and I'll go back to you, Rachel, do you have any tips for those kind of first few patients? How do you select? How do you start with them? And what are those expectations?
Yeah, so another great question, and kind of getting to the nuts and bolts of practice. So again, I would just, I would reiterate that these are not new people. These are not folks that are walking in off the street and straight into your clinic or your private freestanding practice and looking for addiction treatment. These are people that you know. And so, I think the first patient you start with is the first patient that trusts you enough to disclose their drug use. Or their problematic alcohol use, and that they're really struggling and that they're really having a hard time. And that's when you say, I'm going to take a deep breath and I'm going to really dig into this with you, because this is important and this is big and important and you trust me. And so we're going to do this together. I think in terms of starting treatment for opioid use disorder, I will just say that currently it's incredibly hard, at least in my experience, to get someone onto buprenorphine if they're using illicit drugs from the street. And part of that is just that the concentration of fentanyl right now is so large. And 2020 fentanyl is not 2019 fentanyl. It's incredibly potent. It is very synthetic. And so folks are having a really hard time getting onto bupe. So I would certainly encourage anyone who who's going to be starting Suboxone or buprenorphine on patients who are otherwise naive to treatment to really reach out and to get some guidance. However, again, sort of prescribing buprenorphine is a relatively easy prescription, and there are really clear guidelines that you can find from BMC, and it's not a complicated process. So I think if you're comfortable, writing the prescription and going through the process, then that's what you do. And again, really collaborating with a patient and being really transparent and saying, I am new to this and I am learning and I have resources and I have folks I can turn to, but we're going to do this together. I would also say for those first couple of patients that really close follow-up is important. So letting people know, that this is new, that you are starting treatment, for a condition that they've disclosed to you, and that you're not just going to leave them hanging, that you're not going to say, here's 2 weeks of Suboxone, I'll see you later. So frequent phone check-ins, frequent visits in the office, your job is not only a prescriber, but also as a container. And so you're going to help contain this process in the safe space that is your office or your clinic. And really explaining that to patients. And I just outright now tell patients that they can just show up. I may not be able to see them, but one of my nurses can see them, that this is a safe space. If they are feeling conflicted, or if they're high and they're scared, or if something, if they need adjustments in their medication, that this is a safe space. I contain that for them. And so really walking a patient through that process and then really seeing them. I mean, sometimes even every couple of days. 2 or 3 times a week is not necessarily an unreasonable thing for someone who is just starting. And that also leads to an increase, I think, in your comfort level of, oh, right, I can do this. This isn't scary. My patients are getting better. They're stabilizing. And then you build some confidence and you can really go from there.
Ben, go ahead.
I just wanted to, on the dovetails of what Rachel said, about for those new clinicians who are starting out, getting expert opinion, not just about the nuances of treatment, but getting up-to-date information. What you get in your waiver course is maybe outdated. And I hope that, every waiver course is a little different, but the idea of once-a-day dosing for somebody who has gotten incredibly opioid tolerant with what's on the street right now, or without really having an understanding of the profile of what opioids they were dependent on, may not be sufficient. And the idea of, a starting dose of 2 milligrams or, working up from there, we may need to go bigger than the guidelines you learned in your X-waiver course. And talking to somebody who really knows that and says, hey, you know what, the people who are coming into my treatment facility are needing at least 24 milligrams a day, or they're needing it TID or QID. Now, that is definitely ahead of a lot of the labeled use for these meds. But if we want to be efficacious, I think we need to consider those things too. So trying to get a pulse on the kind of what's real in your area will behoove you, because if you start people off on 4 milligrams once a day or 8 milligrams once a day, and what they need is 8 3 times a day, you're not going to have success.
And I would also
resources.
Sorry, Belle. I would just sort of dovetail on Ben and really encourage you to ask your patient. If you don't know what they're using, they do. And people know the difference between what is heroin and what is fentanyl and what is mixed with cocaine, and whether or not this bag felt different than a bag they got last week. And a lot of folks are also not new to Suboxone. So Suboxone is on the street. It's passed around, in communities of people who use drugs with harm reduction to prevent withdrawal or to treat symptoms. And so a lot of times folks will just come in and say, hey, I did really well on 8 milligrams 3 times a day. Like, that is what has worked for me. I may have never been prescribed it before, but I know that this is what works. And so part of, I think, this whole process too is really leaning into that collaborative relationship with your patient. That this is not antagonistic. This should never be a power struggle. you really need to work together and to trust each other. And so if a patient is saying, look, what I'm using is pure fentanyl, this is what I'm going to need to do to get on to Suboxone, they know. I was again sort of having a really interesting conversation with a patient of mine who was really struggling, and sort of walking him through harm reduction and like talking to him about what I've been seeing, from other patients. And he stopped me and he said, Rachel, I know a lot about drugs. Like, we can stop now. And I was like, cool, awesome, you're good to go. So, I mean, just really leaning into that relationship, I think, is important.
Yeah, I think that's a great point. And I think to kind of sum up, what we're really talking about is that starting. And in starting with a select few and kind of keeping closer track and getting your feet underneath you. As an attendee said, there's going to be some kinks, and starting just with a few folks and understanding what those are before saying, okay, now I'm going to roll it out more. And kind of being selective and getting used to the process is really important. Annie, I want to bring it back to you one more time, because anytime, even if you've done this a while, at some point in the process, you're going to say, I've never seen this, I've never dealt with this. And you may be, kind of alone in your practice. Who do you reach out to at that moment for that kind of specific case, and how can you get help?
If there's no one else in your practice that you can turn to that can help you, there's experts here that probably are at a neighboring community health center or within your same institution but in a different department. I know in healthcare we do not a great job of talking to one another. Aside from OBAT TTA, which we also offer those services, there is a telephonic service called Mixed Step, which will go through any complex patients with addiction, and also addiction with the intersection of pain, which a lot of times can be challenging to work with, is the person with chronic pain who says they were self-treating with either illicitly purchased opioids or have turned to illicitly manufactured street fentanyl. For pregnant postpartum parenting parents, there's McPAP for moms that also offers telephonic for parents and for pregnant patients and those that are parenting. If you have any challenging questions, run by a team of experts, both OB/GYN and mental health experts. For a warm line, there's the UCSF Clinical Consultation Center. They have a warm line that is answered by a collaborative member of a team. It could be a pharmacist, a nurse practitioner, physician, a physician's assistant, 9 to 8 p.m. Eastern time. I've had great experiences with them, so it's a great resource. Also, PCSS has a mentor that you can ask, fill out a form, and you can establish a relationship either via email, checking in by phone, however you want to set that in the intensity. They also have a forum that you can post questions and get expert opinion back on the resources. So a lot of times, even though you may be practicing in a rural area and you feel alone, there's a lot of resources out there to help you get started, especially if, I know you can start off with a few select patients. If for some reason that gets more complicated, there's always someone there to help you. You don't necessarily have to have all of your team in-house.
I think that's a great point. I think having used it myself from the emergency department, really great resources, the Mixed App and others, of being able to call and talk to an addiction or addiction and pain specialist about a complex patient and get that call back kind of almost in real time and talk to folks has been an incredible resource. I'd like to switch up and make things a little bit more complicated, and I want to bring you into the conversation, Tom, because I think, when we talk about these complex patients, a lot of times we talk about the intersection of addiction and pain. So in this case, we have a 54-year-old female with chronic low back pain who presents, established in your clinic, and presents for follow-up. She's been on chronic opioid medications. You've been trying to wean down over time with intermittent success. At her visit today, she really says, she breaks down, says she's been having trouble. She's gone so far as to buy illicit heroin to treat her pain. It's led to issues both at work and at home. She's been increasingly sad. The heroin seems to help not only with her pain, but feeling sad. It makes her feel better. And now she's presenting to you seeking your help. And I think this is a common, obviously kind of a common scenario, this intersection of pain and addiction in medical practice. And I wonder, Tom, how do you approach this patient? What is your approach to this patient?
Just my initial reaction. Can you hear me? Okay. So initial reaction, actually, when I, look at the description, I go, oh boy, this is great. This is somebody I can help. So that's, the first, as you laid it out there. But of course, the first thing's gathering more information and kind of sorting out what the patient's goals and wishes and understanding of everything is, really assessing, substance use disorder criteria, the 4 C's that were mentioned, kind of looking at the DSM-5 criteria for substance use disorder. And as you mentioned, as you described it here, there's, at least 2, probably 4, soaring to moderate or severe, which maps over to dependence, which fits with indications for buprenorphine. Just as a side note, the tolerance and withdrawal part of the criteria wouldn't apply here because it's prescribed opioids, so you'd expect just from chronic opioids to have both that, and those wouldn't be part of the criteria. And looking at other substance use and other experience with treatment and managing that, so kind of gathering all that together. But this is somebody who would probably do very well with buprenorphine, either from the treating of the substance, the opioid use disorder perspective, or for managing the chronic pain. So we've got experience with buprenorphine for chronic pain itself, and as compared to full opioid agonists, there's kind of more of a safety profile as a mixed agonist-antagonist, and kind of a general experience that a lot of people actually do better with their pain, or as well, folks that have been stable on agonists are often feeling better on buprenorphine, and the titration of it actually is often easier than full agonists if it's opioid management for pain, since you have the ceiling there.
I want to bring up kind of an interesting point, which you first said, which was that when you approached this patient, you were kind of excited, saying, oh boy, I can help this patient. And I imagine for most of our folks, seeing a person on chronic opioids with chronic pain who is doing worse, that was probably not their first thing that they said is, oh boy, I like this, I can help this person. Tell me a little bit more, Tom, about that. Why you say that, because that is very different, I think, than many people feel about folks who struggle with chronic opioids and kind of get into this realm of crossing into addiction.
So I started off there as well. Oh boy, we're opioids and the buprenorphine was, getting into that in the first place, and learning about it was, in part looking for an answer to that, and then just the experience with seeing the benefit and folks doing better. So these are folks that the management becomes easier, the problem gets laid on the table, and it's, with therapeutic alignment and addressing it directly. And it's just fun to have patients who are doing better, proceeding with life, grateful, happy. Certainly bumps in the roads, but things have not been going well, and typically things are getting better. So that's been my experience, and you get to follow folks for many years and see this work out.
That's great. I do want, and Annie, I'm hoping that you can help us clarify, because there are some kind of legal and regulation clarifications as far as with some of these medications and giving them for pain and then for addiction. And I wonder if you could talk about that specifically with methadone or buprenorphine a bit.
Yeah, I think I've been struggling, especially recently. I had a gentleman who has a lot of chronic pain due to underlying osteoarthritis in the hip and in the legs. And he said, he has a history of opioid use disorder. He's on 24 milligrams of buprenorphine naloxone daily, and divided into 3 times daily. And he said, listen, methadone, I was on methadone for a while. It really helped my pain. I don't understand why you can't just prescribe it for me. I can't get to a methadone clinic every day. And it's really important to highlight that those that even have chronic pain, If they do have a diagnosis of an opioid use disorder, it is not within the federal regulations to treat that as a primary care with methadone in an outpatient setting. If you have a diagnosis of an opioid use disorder, you have to go to a methadone maintenance treatment program where they dispense methadone, do not prescribe it. And that's why you don't find it in the PDMP, and a lot of times you'll have to do dose verification. Although I'll say patients know exactly the dose of methadone that they're on. Like they'll say, I'm on 64 milligrams. I've never had a patient say I'm exactly on 20 milligrams of lisinopril. There's no doubt about that. So, patients are very trustworthy in reporting their dose of methadone. But that's really important to highlight as you start getting into treatment is if someone has struggled with, treating their pain with illicitly manufactured fentanyl or with black tar heroin, that might not be a patient that fits within the scope of being able to be treated outpatient with methadone, and that will come under scrutiny from the DEA.
Yeah, I think it's a good point and something that everyone needs to be aware of. Some of these regulations, we hope, and I've seen in the comments here, about trying to ease some of these, and we too hope that there will be eases and changes. And actually, there have been some with coronavirus as far as easing different restrictions with buprenorphine and things. So hopefully more to come. Ben, I want to turn to you. This person that you get who has pain and other things has just admitted that things have gotten so bad that they've gone to using heroin on the street. So besides obviously addressing that pain and starting buprenorphine and other things, are there other types of harm reduction topics you would address with them at that visit?
Now, can you hear me? I get excited about this particular question, and Tom, I appreciated that you brought up the use of buprenorphine as a replacement for some of these other full agonists that contribute to opioid hyperalgesia. One thing I often will tell those patients is that when you took that dose of morphine every day, or that dose of methadone for your pain every day, or OxyContin, it wasn't just working on your opioid receptors, right? It had a profound effect on your dopamine levels. It affected your serotonin. It affected glutamate. And so a lot of your body has learned to say, all better once that goes down the hatch. And buprenorphine may not do that. You may have, your neuropathic pain might not be as well covered, or this or that may not be as well covered. So I think assuring them out the gate, hey, you know what, we are going to switch you to this. It's going to give you potentially a lot of life back in these other ways. And we're going to need to work with depression and atypical types of pain that come up, and sleep and things like that. So, being at the ready to use other adjuncts like amitriptyline or dicyclamine for belly stuff, or, and thinking creatively. We've heard again and again from all of these different awesome lecturers that this is a huge component of this disease is about isolation and is about loneliness. And this has been highlighted by the COVID-19 pandemic, right? I remember driving by our local place here in Greenfield called the Grapevine, which is a recovery support center. And they had chairs in massive rings, six feet each apart, and I was so glad they were still doing that. But a lot of our patients are struggling with that social isolation even more. And so my most important screening questions for patients, whether they're dealing with pain, opioid dependency, pseudo-addiction, which is a term that's getting sort of phased out, or outright addiction, is talking about your social capital. Who's your family? Who are your friends? Who can you wake up at 2 in the morning for a ride or a shot of Narcan if you need? And how can you involve them into your care? How can you share accountability? Can they come to appointments with you? Can you share with them your goals? Can you guys have a phone every day, et cetera? And that when you start building it as a shared experience and bringing out of isolation, the better. The last thing I think about is that when we think about those dopamine levels and other ways to get it, some of the most successful recovery programs that are out there, whether they were abstinence-based or used MOUD, helped people get their dopamine from other places, including hobbies and purpose and meaning. And if we as providers can make this a socially acceptably supported disease. If your patient can show up every Wednesday to the ring at your clinic and get out there and say, all right, hey, how far into your recovery are you, man? Awesome. And it can become a positively visible thing. I think we can make tremendous headway here. And I think that means on a bigger level, making sure that your clinic is, or your health center is supporting the local runs in, or charity events, is showing up for those, is visibly saying, we see this as an issue and we support you in it. So come on out with us. So the takeaways from that, I think, are get dopamine in another place, make sure you're being creative with other meds, capitalize on social connectivity, and when permissible per HIPAA, find ways that you can get these folks together to support each other.
I think that's really important, and you bring up during COVID the social isolation and having those resources, and be it recovery coaches or other places where folks can talk with other people, the use of telehealth and other types of things. That's great. We have a few minutes left, and I wanted to hit on a couple of the questions that have come up in the chat. One of the big ones that came up that I want to address, and I'll open this up to Tom first, but then to the group, is everyone kind of worries about the UTOX and how do I do it and what do I do? And then, oh, there's buckle. How do I interpret it? Can you just a general approach to this idea of testing, which honestly I think has really changed over time in how we use this?
So yeah, so generally testing is recommended to be part of care and is helpful, but it's important to keep it as within meeting the goals, and it's not a gotcha sort of thing. It's to try and help align the history and the report that we're getting together, and it actually can be a nice kind of reinforcing thing, and people often want to see the results and have that done. Actually, during COVID, we've really run into the difficulty doing that and doing stuff with less visits, and so far with much less testing, I think most places' experience has been that the bottom didn't fall out and people actually, by and large, continue to do well. So it does raise a question as to how much it does add. I think there's a lot of questions there still to be answered, of course, but the oral versus the urine testing, some places are still doing observed urine testing. I think most places have stepped away from that, and just the whole approach and the feeling of it. The oral testing is nice in that it's observed. It's not a thermometer, so you can talk with the swab in the mouth. So while you're talking, you can just take care of it. It takes a few minutes to do. The difference between what you're getting on the results is the urine collects things over a longer period of time. So you're gathering urine that takes longer that hangs around longer. So you get a few more days of levels there generally, whereas the buccal, you're basically getting plasma type levels, so it's more of a blood test sort of thing, so you might not pick stuff up as much. So it's a little probably less sensitive, particularly for the short-acting medications.
Yeah. But it sounds really like the change in that it's not something to fret, it's not something to hold up. It really is there to try to help and to guide treatment and to help patients, rather than, just as you said, rather than a gotcha, rather than a, we need to abide by this. I think that's really important. I want to give folks a quick chance. We have about a minute left. We have a whole lot, I think, I can't see folks, but what I think is you have a whole lot of providers that are really interested and probably a bit new in this and want to start out. And you all are really the experts in this. And what advice do you give that person who's like, I've drunk the Kool-Aid, I am ready, I see this as a disease, I want to start, but I'm still scared to do it. What's your one line to them? I'll put it on the spot, but Rachel, I'll start with you. Go ahead.
Gosh, I would just say, you can do it. I still feel much more nervous prescribing insulin than I do buprenorphine. And that is just a fact. That's like my reality, and that's how I practice. And so I think, you pick a patient, that first patient that discloses to you and has that trust in you, and you just do it. You just jump in and know that we've got your back, and there's tons of resources, and that you were the best thing for your patient. They trusted you. They told you. And so taking that and going with it and building that relationship and helping your patient get better. That's what we do. That's why we're here.
Great.
So.
Tom, I'll jump to you.
Likewise, I'd echo and all that Rachel went through before as well. But you can start with one person, and you can have support as you do it. So you can have somebody lined up to just talk you through it, and it is just quite doable. And I wouldn't turn back. I haven't turned back.
Very good. Thank you, Ben.
Yeah, insulin's the most dangerous drug we prescribe, right? And like at some point in every new grad's career, you got to get comfortable doing it. But you don't do it alone. And so I think my two pieces of guidance are, one, find a mentor, find somebody who you trust who's done this, even if they've only done it for a year longer than you have. Someone you can bug. And the other is to harken back to Rachel's bit about self-care. We're not going to talk to our mentors about the things that fit perfectly into the algorithm. That's what algorithms are for. We're going to talk to them about things that are messy and sticky and challenging. And so the second piece of advice, first, find a mentor. Number two, find somebody or your systems for support, because you're going to be seeing a lot of the comorbidities that go with substance abuse, and that includes trauma and child abuse and hearing really rough stuff and making sure that you have a place to put that and process it. I guarantee you this will be more rewarding than challenging.
Thanks, Ben. Annie.
So kind of going back to, what Dr. Lincoln was saying, following patients temporally has been such it's such an honor and privy. I mean, I think one thing is prescribing the medication is easy. The work that our patients do to achieve recovery is what is hard. And so whatever we can do to support patients who are struggling in order to build up their social structures. I mean, these are patients that have lost their families, their children, their housing, like all of Maslow's bottom hierarchy in the lower levels. So anything that I can help to make sure that we rebuild that individual to be the best father, son, mother, daughter, anything, is really helpful. So I know that we talk about prescribing is easy. It is. We still need to support our patients because everything else they do outside of that encounter is really, really hard. And everything we do is great. I think we need to just be great about offering social supports. And I know that that is what our patients struggle with. So, I think just being here and entertaining the idea is such a big jump from being from contemplation to planning and action phase. So I know so many people go through the waiver training, very few go ahead and start prescribing. So just being here and learning and listening to us and spending your Thursday night, it just shows how much you're putting your dedication you're putting into that. So thank you for being here.
That's great. Thank you, everybody. And we will post the links that we talked about in the chat, and we will, for those that can stick around, try to answer any questions in the chat. I want to thank Annie Potter, Tom Lincoln, Ben Woodard, Rachel Katz. Thank you very much for your time.